mention. So uh, next talk will be by Dr. Sathyan sir. He is not, unfortunately he couldn't come today, so he's given a voiceover. He'll be talking on laser for angle closure glaucoma, laser iridotomy and iridoplasty. Sir is the wait a minute, wait a minute, wait a minute. Sir is the president of GSI and director of Sathyan Eye Care Hospital, Coimbatore. So he'll be talking on peripheral iridotomy and iridoplasty.
To reduce the risk of chronic enclosure. There are a few safety precautions one has to look into, like a bleeding disorders or the patient is on any anticoagulants. You have to take caution. Once you do the ablation iridotomy, you may come across having the hypema. It could be sometimes vision threatening. So you have to be cautious. The consent form has to be given to the patient. Any procedure where you take the consent, similar to the you take the consent form from the patient before you do the procedure. There are several risk factors, very minimal, but IOP spikes can be seen in few cases. The visual dysphotopsia and the corneal damage also we may come across in few patients. The pre-procedure preparation is extremely important, like constricting the pupil by using dilatation 2%. Apply the medication and wait for at least half an hour to 1 hour. Like once the pupil stretches out, then it is easy for you to do the guideline. Once the pupil is constricted well, then there is a time where you can really identify the trips and you can perform the guideline quite comfortably. Sometimes the pilocarpine can give some headache, but you can talk to the patient. When they complain to much of a headache, then probably you may give the paracetamol tablet. There's an alternative way if you don't want to use the pilocarpine. You sign the cards in the other eye, and I which you want to do the laser, you sign the bright light from the Sathyan. Because of the tensions or reflex, you can see the pupil is getting constricted. So this is a very sustained reflex once you put the light in the other eye. And this is very useful in cases where you don't want to use the pilocarpine. Once you can see the tips by showing the light in the laser eye and other eye you show the light torchlight, then it is an easy procedure to perform. It's not very difficult to see. So the next thing is preparing your machine. One may have different, you can have different machines. So I'm not going to discuss about the machines in detail, but there are Indian machines and also the imported machines. Imported machines mostly uses the Gaussian mode where you may have to use the powers of around 4 to 6 millijoules. In Indian machines where it uses the super Gaussian mode, you may use about 2 millijoules as the power. So I use this machine, so I have my settings at 2 millijoules. And using the lens becomes mandatory in most of the cases. But if you have a clips very well seen and a thin iris, you may avoid sometimes using the lenses. So lens will give a good control over the eye. The laser will be focused sharply and which really helps you to minimize the laser loss. And also it can really help you whenever you see a minimal bleed or micro bleed or micro hypema. Lens is pretty useful when you're doing the tablets or the iridotomy. So this is how you put your bundle lens. Ask the patient to look up and put the lens in the points. Always use the focusing light of the slit so that the other eye patient can look at the fixation light. So then it becomes easier for you to do the application. So the first step is once you put the slit on and you can see the thick shell, that is where you have to really do the laser, that is the thinnest areas. Then you can see the positioning of the PI. It is between the colorate and the peripheral iris. Don't go too much into the periphery also. Same way, don't come too close to the colorate. Somewhere in between you can come the PI, something like this. You can see that very clearly. This is the positioning of the PI, and you can do any of the locations. I preferably avoid the superior because patients may have the visual disorders more than they're doing the superior. There are several publications to show that the superior location has no potential for a visual disorders. This is the size of the PI. Don't have to do too large a PI. If you do a larger PI like this, one may encounter having the central lens because there's only a ruptures in the PI. So try to avoid doing any large PIs. So looking at the end point, the moment you do the laser, you look at whether there is a gush of aqueous coming in. You can just magnify if you feel that it is too small, the magnification, so you can really appreciate the gush of aqueous coming with the pigments coming into the anterior chamber. And also sometimes you may appreciate the deepening of the anterior chamber as well. So that is the end point. Post laser medications, you can give the steroids 4 times in the tapering dose over a period of 7 days to 10 days. And you may give timolol if the patients are not comfortable taking the isotonic tablet, because not everybody is very comfortable taking the for a couple of days. Or if you're giving timolol, if you feel that iodine is to control, you can give it timolol daily dose. So post laser, you see the IOP, and also you have to do the gonioscopy and follow-up visits to see that problems with the angle opening has happened. It will really help us understand that. So these are the several complications, but the commonest ones may be the microangioperimas. Rarely you see pupil distortions and also blurred vision. Inflammation sometimes my patient appreciates by telling that when they feel the glare of the stoppage of the steroids. So you can increase it for a few more days, number of days, so that it becomes reduced. The patient becomes more comfortable. Increased IOP is another one. Then visual dysphotopsias. But whenever you are taking up these patients for a cataract surgery post laser PA, as I mentioned earlier, you look at the zonal ruptures. About the laser iridoplasty, it is not a very commonly done procedure. From this slide, you can see that there are a lot of laser marks in the peripheral laser, but we usually use argon laser so that it constricts. So we have to use a photocoagulator and then we are doing the iridoplasty. The peripheral iris is getting contracted, so the angle opens up nicely. To a reasonable extent, if there is no significant closure. If there is a significant closure, you may not really appreciate. You can see it another way. Once the IOP comes down to a reasonable extent, you may do the laser, like SLT, or if you want to go for, in spite of all this IOP side, you can go for a nucleotomy. So in short, we have discussed about the laser peripheral iridotomy as well as on the iridoplasty. Thank you so much.